Thank you so much. Thanks everyone for giving up your lunch hour to join us to talk about MASLD and MetALD, which is somewhat still the new kid on the block. My name's Lindsay Yoder. I am a PA at Indiana University in Indianapolis, Indiana, and I specialize in outpatient general hepatology with a very large practice that focuses on MASLD, among other liver disease etiologies. So make sure you take a second, scan this QR code so you can record your attendance for the meeting. And we're going to get right into a patient case. So this is Ashley, a 52-year-old Caucasian woman who was referred for evaluation of an abdomen ultrasound that showed mild hepatomegaly and increased hepatic echogenicity consistent with hepatic steatosis. She feels well, no complaints. This is a patient I see almost every clinic session that I have. Her BMI is 29.4, so she is overweight with one of those features of metabolic syndrome. And then as we get more medical history from her, a few other features of metabolic syndrome come to light here. She has polycystic ovarian syndrome, hypertension, hyperlipidemia. On physical exam, she has a smooth, non-tender liver edge. She's on a few of those metabolic syndrome medications in addition to a multivitamin and milk thistle. And then as far as her social history, she drinks approximately 2 glasses of wine per day. She is a little bit hypertensive. Again, we already discussed her BMI being in the overweight category. Otherwise, her vital signs are there. She has some hepatocellular liver enzyme elevation, AST a bit higher than ALT, not quite in that 2-to-1 ratio that we think about with alcohol-associated liver disease, and also a little bit of ALK Phos elevation, slightly elevated bilirubin, but she does not have thrombocytopenia, and she has A1C there of 5.9%, so right on that edge of prediabetes, diabetes, and a little bit of hypertriglyceridemia. So we are fortunate at IU to have a FibroScan in our hepatology clinic, and if she had a FibroScan, it looked like this. Her CAP score, which I usually focus on first, quantifying hepatic steatosis, is 310, which would put her in the definite severe hepatic steatosis category. And then her liver stiffness measurement there in kilopascals is 11.4, right on the border there in the advanced fibrosis category. So what are we talking about? This big, broad umbrella terminology used to be NAFLD, NASH, alcohol liver disease, but now we have a big umbrella that is steatotic liver disease. On one end, over to the left, we have what we know and love and is pretty straightforward, which is our metabolic dysfunction associated steatotic liver disease, or MASLD. This is what was previously referred to as NAFLD. And then if you have confirmation of inflammation, that's our MASH, metabolic dysfunction associated steatohepatitis. And then it's easy to go kind of over towards the right side and say on the opposite end of that spectrum, we have alcohol-associated liver disease. And then the grayed out boxes there are when you have steatosis in the liver from things that are not related to alcohol, not related to metabolic dysfunction, things like drug-induced liver injury, Wilson's disease, cryptogenic etiologies. And so what is sort of new with this nomenclature is that bigger square box in the middle between MASLD and ALD, and this is MetALD, where you drink enough that we can't rule out that alcohol use as somewhat contributing to the hepatic steatosis, but you don't drink enough alcohol for that to be the predominant driving risk factor. So you have metabolic syndrome risk factors, but you also drink enough alcohol that we can't negate that as a risk factor. I like to think about this in my mind. I quantify this easily more on the average daily alcohol intake below. And so those numbers there are in grams. So if you drink more than 20 to 30 grams of alcohol, you're going to be in that MASLD MetALD category, but more towards the MASLD predominant end. If that daily average alcohol intake is more towards the 50 to 60 grams of alcohol per day, then you're swinging more towards the alcohol-associated liver disease and within that diagnosis that's in the middle, which is MetALD. And so again, what does that mean? How do we quantify that, right? Because patients aren't going to come in and tell you, I drink, 50 grams of alcohol a day. They're going to say, I drink a 6-pack of beer a week, or I drink, like Ashley, a couple glasses of wine a night. And so I kind of keep locked in my brain that one standard drink is about 14 grams of alcohol. And then depending on what type of alcohol the patient is drinking, I usually try to remember, and I keep a little note in my cell phone actually, your regular, like light standard, 5% alcohol beer, like your Miller Lite, Coors Light, Bud Light, that's 12 ounces. So that's 14 grams is 12 ounces of beer, or 5 ounces of wine, or 1.5 ounces of liquor. And then there are some other things there. If your patients drink cordials or brandy, this reference is good. But knowing that is helpful. So you can, so I'm going to go back to this real quick, quantify that. So again, in my mind, for MASLD, women can drink up to 1 alcoholic beverage per day. Men can drink up to 2 alcoholic beverages per day and still remain in that MASLD category. Once you drink more than 4 drinks per day, you're all the way swung over to that other side, the alcohol-associated liver disease, and MetALD is right there in the middle. So for women, if they're drinking 2 to 3, up to 4 drinks per day, for men, 3 to 4 drinks per day, those are the individuals who kind of drink enough that they're not purely MASLD, but not so much that they're alcohol. So that's the MetALD category. And so why does this matter, right? Basically, this is a dual etiology. You have 2 hits, 2 insults to the liver, right? We have the MASLD risk factors, insulin resistance, diabetes, obesity, unhealthy diet, sedentary lifestyles, underlying genetic risk factors, and then the epigenetic, but then you add alcohol in, so you're further impairing the lipid handling, creating oxidative stress, leading to cell death, and then overall you're going to get accelerated fibrosis and disease progression in the liver. In addition, there's an inflammatory response, and then the disruption to the intestinal microbiome. And I like this because this kind of shows you the spectrum at the top, right? Depending on your hepatic fibrosis stage, and then depending on the underlying etiology, whether it's MASLD, MetALD, or pure ALD, this gives a 5-year risk for liver decompensation. And so you can see overall, this makes sense. We know that the lower hepatic fibrosis, the lower risk for decompensation, and those with MASLD have a lower risk compared to those with alcohol-associated liver disease, and MetALD is somewhat right there in the middle. The highest risk is those that have alcohol-associated liver disease and advanced fibrosis or cirrhosis. So what's really important, right, in all of this is you can ask your patients, what do you drink, how much, how often, and they may or may not be telling you the truth, right? So we know we have patients who come in with fatty liver disease. They have risk factors in the metabolic space, but you add alcohol in, and all of these things are going to increase their risk for developing inflammation and then increase their risk for developing advanced fibrosis and cirrhosis. So different ways that we can assess, different methods we can use for alcohol use. Certainly questionnaires. Our clinic just recently started asking every patient in the hepatology clinic, having our medical assistants when the patient's getting roomed, do an audit C. It's quick. It's in our EMR, so before I go in to see a patient, I can see how they answered that question. I do usually, if someone has a CBC, look at their MCV. This tends to be abnormally high in patients with excessive alcohol use. Annie is a cool score from Mayo that you can plug information in as far as a patient's liver enzymes, age, platelets, and then it will tell you how likely a patient with hepatic steatosis is to have alcohol as a driving factor of their hepatic steatosis. And you can just Google ANI Mayo score or ANI liver, fatty liver, and that score will come up and is available for free online. You can do urine ethanol glucuride testing. We've sort of gotten away from this as we've moved towards PEth, a little bit more on that later. But what this study showed was that in the patients who had fatty liver disease, anywhere between 25 and 28.6% of patients who had been labeled NAFLD or MAFLD actually had moderate to excessive consumption of alcohol. And so you can ask, but generally having these other methods to really try to confirm what your patient is telling you are important because the correct diagnosis is important. So again, thinking about steatotic liver disease, certainly if someone has evidence of metabolic dysfunction, these features here, elevated BMI, elevated fasting serum glucose, hypertension, hypertriglycerides, or low HDL, then they meet that diagnosis for MASLD. But something to keep in mind is in those patients that might have isolated hypertension or hypertriglycerides, these are patients you want to think about PEth testing. For me, I have gotten into the habit of all new patients who come in with hepatic steatosis of doing PEth testing just to ensure that we have the right diagnosis. But these could be clues that tip you off that if that's not your practice and that's not your habit, those might be patients to think about PEth testing. And so again, following that algorithm down, certainly if there is no evidence of alcohol use, you're going to give a diagnosis of MASLD to those patients. When you're assessing alcohol use, again, you want to ask your patients, what do you drink, how often, and how much, so you can understand the number of drinks per day or per week, if that works for you. Per day just is easier to stick in my mind of that quantifications. So again, considering PEth testing to confirm what they have shared with you. And again, if they're drinking more than 4 drinks per day on average, that's going to be alcohol-associated liver disease. If it's 1 or fewer for women or 2 or fewer for men, they still can qualify for MASLD, but right there in the middle is going to be that MetALD diagnosis. And they put some PEth values down there, which I think is helpful, right? So if the PEth score comes back and it's greater than 200, that's consistent with chronic or excessive heavy alcohol use. So that's alcohol liver disease. Certainly if your PEth is negative and it's less than 20, that's confirming MASLD. Somewhere in the middle there where someone's PEth is positive, but under 200 could conceivably be consistent with that diagnosis of MetALD. And that's just highlighting there those things to think about. So for our patient, Ashley, she had a PEth and her PEth came back at 120. So that is in line somewhat with what she reported as far as the 2 glasses of wine. And so we have moved to using PEth over really any other alcohol biomarker, and this is available at LabCorp. Most labs can do this, but it's detectable for 3 to 12 days, even after one single episode of binge drinking. And really, this is going to give you a good idea of alcohol use in the last 2 weeks. If someone binged the night before you do the PEth, it can certainly be a little bit more elevated and not necessarily reflective of their average over that time span. But generally, if someone has abstained, for more than 2 weeks, you're expecting that PEth to be negative or near negative. So it's a good source of truth. And then this isn't something that tends to vary by sex, no differences between men and women in terms of the PEth level and the number of alcohol units consumed per day. So this is a study that looked at 659 patients who were screened. Several of them were excluded because they didn't meet particular criteria, like they also had concomitant viral hepatitis, history of HIV. And so 617 patients that were enrolled, they excluded anyone who were never drinkers or had missing data. They were left with 333 patients, and then excluded 236 that didn't meet this alcohol consumption criteria. And when it boiled down to understanding based on PEth and what was reported, 97% of that 659 patients who had excess weight actually ended up or suspected to have MetALD, which is around 15%. So just to give you an idea when you're thinking about how many patients might I end up finding if I do a good history and good alcohol biomarker, this was a study that kind of quantified that. So again, Ashley has this medical history consistent with the hyperlipidemia, hypertension, PCOS, and there is evidence of alcohol and hypertension looking at 32 different randomized controlled trials, over 700 patients, that alcohol has a biphasic effect on blood pressure. So it'll actually decrease blood pressure up to 12 hours after you consume it, but then that blood pressure is going to rebound and increase after that 12-hour mark. And you can see the table and the values there just proving that biphasic effect. And then as far as triglycerides, 10 hours after 2 standard drinks containing alcohol or water, you can see differences here. The yellow or gold, I'm not sure what color it looks like on your screen there, is the group that only had water. The blue on the graph to the left there is the group that had alcohol. And so you can see the effects of alcohol consumption there on triglycerides. And so going back to that algorithm, pointing out that patients with isolated hypertriglyceridemia or isolated hypertension without any of those other features of metabolic syndrome should sort of pique your concern or curiosity to really verify if someone tells you they do not drink any alcohol or rare alcohol use. Probably really want to think strongly about getting some kind of biomarker to confirm that. So Ashley, with all of this data, putting this together, right, ends up getting a diagnosis of MASLD predominant MetALD. And so current treatments, right, how are we going to approach treating Ashley in the clinic? We're going to talk to her about diet, Mediterranean diet. We are big fans of, right? Lowering your consumption of processed food, fast food, red meat, excess, carbohydrates that are not our good whole fruits and veggies. Exercise, we'd like to say at least 30 minutes a day, getting your heart rate up most days of the week. Hopefully these things combine to lead to some meaningful weight loss. And then as far as if she's a candidate for resmetirom or not, she is someone who I would consider resmetirom, but I would counsel her to reduce or ideally stop her alcohol consumption, right? The thing with patients who have MetALD or MASLD is, again, that's already one insult to the liver that they have. And so through diet and lifestyle modifications, they can negate some of those risk factors and change some of those environmental insults, but we can't change their DNA. We can't change their genetic predisposition, and a lot of those things we know are genetically predisposed in the first place. So really counseling them that there are some things you can control. One of those is alcohol consumption. So if I can't change your DNA yet, trying to reduce any and all of the environmental risks that are within your control are important. So I do counsel my patients with MASLD or MetALD to try to save alcohol consumption for very rare special occasions if they must at all. And then again, because she is on that border of advanced fibrosis, does she need HCC screening? Yes, she could be a candidate for liver cancer screening with that advanced fibrosis. And so the ideal MetALD definition for clinical trials is something to talk about because we need objective biomarkers, right, to overcome the idea that patients frequently will underreport their alcohol use. And then this can help us have a standard assessment of recent alcohol use and then certify those who are abstinent so that the exact risk factors that are playing into hepatic steatosis, whether it's MASLD, MetALD, or ALD, are important. This helps us really understand what's driving that liver disease, right? And then something that can be tricky, right, is thinking about the last 6 to 12 months, and what is alcohol use during that time? What was alcohol use before then? How far back do we go? Again, these are things that we want to keep in mind and get a really good, thorough history from our patients. So, take home messages. We have this new kid on the block, this new definition of MetALD. Again, alcohol intake beyond 140 to 350 grams and 210 to 420 grams per week for women and men, respectively. Clinical criteria can underestimate MetALD and alcohol-associated liver disease, so getting an objective biomarker like a PEth helps you know with more certainty than you do without it, exactly where someone falls. And again, it's important that we understand all of the drivers of liver disease that are present, so that we can reassess over time, are our interventions working, our education, focusing on diet, lifestyle. If you think someone has MASLD and you're putting all this time and effort into educating your patient on that, linking them with a dietitian, helping them get signed up for a gym membership and these things, and you're not seeing a lot move, if you don't have good history or if your patient is not forthcoming and we haven't checked and sort of confirmed, then there is a whole other side of a risk factor with some of that moderate alcohol use that could be contributing that we didn't get a chance to address and counsel and educate our patient on, if we don't know for sure. So clinical criteria, criteria for clinical research, again, this is important because we want to allow comparisons among different sociocultural groups and their realities to make sure that intervention, medications, clinical trials, treatments are the same, and these interventions are applied, and the outcomes are, what we expect based on the known risk factors of pure metabolic risk factors versus alcohol, versus those that have a little bit of both. So there's another QR code here if you want to take a second to scan that. This gives more disease state education through the GAP MASLD MASH Community Network. And then there's a ResDifra podcast or webcast as well. So again, thank everyone so much for giving up your lunch hour here to spend with us. And I'm happy to take any questions and if anyone has any.